So we're going to have a panel discussion right now that's led by Emma Roberts of the National Harm Reduction Coalition. We're going to talk to providers and get their perspective on what's working and where change needs to happen. So Emma, I am going to turn this over to you and I'm going to stop my share.
Thank you.
Absolutely.
Can you hear me okay? Good morning and good afternoon for myself. I'm joining you. I'm so happy to be joining you today, my West Coast colleagues and partners, and see so many familiar faces and names on this screen. I'm joining you from a chilly, rainy New York. I'm in the East Coast. And that makes me extra grateful to be with my West Coast folks today, because I have not been allowed to come and travel at all to be with you all. I regularly travel around the country, many of you know this, in my role as a Senior Director of National Capacity Building at the National Harm Reduction Coalition. And I've not been able to do that. I'm regularly in Oakland about twice a year and then Zooming, flying around. Instead, I'm Zooming all over instead to be with people. And I'm really grateful to be joined by 3 colleagues today and folks that the National Harm Reduction Coalition has had the pleasure of working with over the years to join this panel. And in a moment, I'm going to ask them to introduce themselves and as part of kicking off the discussion in a moment. For those of you that don't know me, I've been involved in harm reduction and syringe service programming since the mid-90s. I'm from the north of England. I was involved in setting up programming there when harm reduction was very new to people, and I've been in America for 12 years and I ran syringe service programming and mobile medical and dental services in New York City for many years before I joined the Harm Reduction Coalition full time. So really glad to be with you. And we have a short amount of time to do this discussion today. So I'm going to kick us off because I want to make the most of the panelists' time that we have today. So the first question I'm going to ask folks to share with us, and we've got Heather and Loris and Stephanie to join us, is to introduce yourselves. And can you start by talking about, how's syringe service programming going where you are in your state, and what's going well, what needs to change or improve as part of the introductory question. And I think I'll kick off with Loris, if that's all right.
Hello, good to see your face on the square, Emma. Hello all. Yes, so my name is Loris Mattox, and I am a capacity building specialist out of California Department of Public Health, Office of AIDS, the Harm Reduction Unit. And I've been there for a little over a year now, and I came by way of serving as executive director of a rather large syringe service program in Oakland. I was the executive director there for 10 years and worked there for 15. So have some direct service background. Before then, if we really want to go back, I'm aging myself, started off working in the Tenderloin in San Francisco, walking up and down the streets, passing out condoms and doing testing. Age myself. So yeah, CDPH, or the state of California, what we're doing that works well. So when I think about that, like I think of the we, right? So there's the syringe service programs, CDPH, and also like advocacy groups and organizations. I feel we do work well together when we're thinking about our root, right? The bottom line, which is to increase, harm reduction services statewide, secure funding and resources for programs. And something I hope we get to touch on a little bit later is like working to change existing law, to catch up with the times. And what we at CDPH do well, I believe, is we have a state law that allows us to authorize people or entities to provide syringe access services in their communities. It's a pretty straightforward process. It usually takes about 2 to 3 months. And, it's needed in communities that are experiencing local opposition and minimal support for harm reduction efforts, right? So we're able to get those programs launched in those conservative areas, especially in communities too that are vulnerable to, HIV and viral hepatitis outbreaks. And of course, now with the epidemic around fatal opioid deaths. So we have the state authorization process. And what also works well, we have a supply clearinghouse. So the Office of AIDS Division, we have a fund that offers up a baseline level of harm reduction supplies for newly authorized programs and existing programs. And so they're given an annual allocation that's based on current epi data and other factors to provide them with supplies that they can order through the North American Syringe Exchange Network. And I think it's pretty impactful. When you think about harm reduction services, like how it starts, it's usually a group of people in a community who sees a need, right? And then they commit themselves to address the need, and they coordinate, and they're primarily volunteers or people who are using, and it's just, like at a grassroots effort to help folks. And so the clearinghouse is pretty cool because it assists those programs with making the supplies, getting the supplies out in the community. And let's see what works well. So obviously, more recently, the California Harm Reduction Initiative, which is how I transitioned from a CBO to the state. It's the California Harm Reduction Initiative, or CHEERI. It began, I believe it was in like 2017, I'd say. All of the state syringe exchange programs gathered in one space and, presented and shared. And there was just this huge brainstorm where we were asked at the time, what do you need? Obviously it was money. We all stated, I was the ED at the time. We all stated that we needed money to just, strengthen our efforts, expand in communities, and transition from volunteer staff to paid staff. And it was Drug Policy Alliance and the National Harm Reduction Coalition. They worked closely with the state programs and organized through coordinating visits to the state capitol. And I remember sitting on couches at legislatures' couches and hyping up our program. And ultimately, it led to the budget request that was approved in 2019. And what CHEERI does is it provides over 15 million in funds to support programs and strengthen programs, and also strengthen our substance use disorder response. And one thing that I thought that was quite cool was how it was packaged, right, to legislatures. So this wasn't this thing of us saying, our budget request is to get syringe service programs money to increase syringe access. It was framed more to legislatures as a budget request to assist with our overdose prevention response. And I remember thinking that was quite clever because it took the focus off of the actual syringe, which gets people hung up still to this day. I don't understand why. And it placed the focus on the big picture, right? Which is keeping people alive. Yes, and so those are some of the things that we do that work well. It's just like this, coordinated effort that we have with the state health department, with county health departments as well, and programs and advocacy efforts. Yes.
Thanks, Loris. And what I really appreciate are those examples you've shared there. They are kind of so in alignment with the stuff that we're hearing from states across the country, where resourcing and funding is such a stressor. Like the whole idea of the clearinghouse, so many programs are saying to us, we don't get dedicated funded because of the federal ban, to get resources. So having a clearinghouse and taking that stress away, we had that in New York too, taking that pressure off the program so that they can really focus on other things is a really amazing example. And also the budget request, the way you framed that, because you're so right, in many of the states in the West and the other parts of the country, trying to get that dedicated funding through to people is still really difficult, right? There's still a lot of controversy around this work.
Right, right, yeah. And yeah, I'll give space to others, and I know we'll get into the juicy bits as well. Yeah.
Yeah, I'll come back to you. Yeah.
Okay.
Stephanie, would you like to tell us?
Oh, you're muted, Emma.
I accidentally muted myself. Stephanie, would you mind introducing yourself and talking about your work in syringe service programming and what's going well there?
Absolutely, Emma. So my name is Stephanie Cole, and I am the Prevention and Harm Reduction Program Director at Open Aid Alliance, and we are located in Missoula, Montana. And I have been with the agency for 10 years, and we started our SSP back in 2013. So I was there at the very beginning, and at the very beginning, I was in charge of the SSP, the day-to-day activities. And so I did a lot of direct service for several years. And now I have transitioned to the director of the program. So I don't do as much direct service anymore, and I do more of the higher level. You know, I do some grant writing and program development and evaluate the program and do a lot of community outreach and engagement. And in thinking about what works well, you know, in Montana, I would say that just at a base level, what is working well right now is we are reaching the desired population, and we are spreading a harm reduction message throughout the state. It has taken time for a lot of people throughout the state of Montana to even know what harm reduction is and what that means. And so we're at a pretty exciting place, I think, in Montana, where we're getting a lot more state support, and we are starting more programs across the state of Montana. If you're at all familiar with Montana, and we are very, just generally quite conservative, we are a red voting state generally, but where I live in Missoula, Missoula is much more progressive and much more liberal just in general. And so starting our SSP in Missoula was much, much easier than it has proven to be in other areas of the state. So back in 2013, the fixed site that we operate now in Missoula, that was the first publicly accessible or above ground SSP in the state. And we are very, very busy. Our program has grown exponentially since the start. When we, you know, at the beginning, we were kind of focused on, okay, supply, distribution, syringes, and safe disposal. But we have grown into a truly holistic harm reduction program where we have a very robust overdose prevention and response training program with free naloxone and fentanyl testing strips, wound care supplies and education. We do HIV, HCV, and STI testing and counseling, PrEP education and warm handoffs to our local clinic, MAT education and warm handoff referrals. We offer SSP participants hydration and nutritious snacks. And we recently have started distributing meth pipes, which in Montana, we are realizing we're reaching a whole new population of folks that are hungry for harm reduction resources, though they are not injecting. And so I think the other thing that is working well is that we have been around long enough that we have developed trust within our participant group. And I think that goes a long way. The other thing that I want to acknowledge that I think that is working well is in regards to policy, is that in 2017, we worked with a diverse coalition of stakeholders and legislators, and we did amend our Montana drug paraphernalia law. And that was a big deal. So now we, as SSP providers, so staff members, volunteers, outreach workers, we are all protected by the law to operate. So what that did in Montana is it did make it so that other SSPs now feel comfortable actually starting. At Open Aid Alliance, we started before there was legislation because it was a gray area, and we thought, we see this need, we need to do it. But we know that Missoula, it was a much easier sell for our mayor, for our police department, for our city council. And a lot of communities in Montana do not have that comfort level. So what this amending this paraphernalia law did allow other smaller communities to feel comfortable starting their own programs. And then that same year, they also did, I think Montana, there were 3 states that didn't have any official naloxone access legislation on the book. So I think it was Montana, Wyoming, and Kansas. And so in 2017, we also did get official naloxone access legislation and a Good Samaritan law on the books in Montana. So in 2017, we really saw some movement. We have a long way to go. And I'm sure Emma will ask later about some things that need to change, and I can go into greater detail about how, in my opinion, we need to advance more legislation. But I think I will end there because I know we are tight on time, and Heather needs to introduce herself.
Thanks, Stephanie. Yeah, and I will. I'm going to definitely circle back to some of that legislative pieces alongside, like, what are some of the other challenges? We'll talk a bit about that next. But and also what I heard you uplift there is that idea that syringe service programming is so much more than just syringes, right? And that's why we've changed our name over the year, right? When I started, it was needle exchange, then it became syringe exchange, then it became syringe access, and now it's syringe service programs, because we want to recognize how, you know, the holistic approach that programs are taking to drug user health in general, right? So yeah, I'm going to introduce Heather, last but not least, of our 3 panelists. And you know, so grateful. I got to work with Heather's team and come and train their team in the early stages of syringe service program in Utah. So Heather, take it away. Tell us about what's going on in your state.
Hi, Emma, and hi, everybody. Thank you. I realize this is giving me weird, like Bob Ross hair, this background. But anyway, welcome, and hi, Randy, and everybody. Thank you for welcoming me here. Again, my name is Heather Bush. I work at the Utah Department of Health. I am currently the HIV team lead, which means I oversee our HIV prevention, surveillance, and syringe exchange programs. But I was the syringe exchange coordinator. I was kind of thrown in. Utah's a little bit different in how we came to be a syringe exchange state, in that we didn't have really any existing harm reduction organizations. We didn't really have anything happening, especially like what Stephanie said, above ground. But all of a sudden in 2016, big surprise to all of us, we got a syringe exchange law passed by our conservative legislature, which we were all very shocked. But it went through along with some other opioid and naloxone legislation. And literally nobody had any idea what that looked like, what that meant, where to even start. We had no organizations, we had nothing. And so they looked at me and literally said, so do you want to start a syringe exchange program? And so with the help of Emma and other people at the National Harm Reduction Coalition and people at NASTAD, we were able to pull people together and pull the pieces together and try to figure out what a syringe exchange program looked like. We also, our friends from New Mexico, we copied literally from them a lot. They were very generous with their time and allowed us to come in. And someone once said about our program, they said, it sounds like you're simultaneously trying to fly the airplane while you're still building it. And that was pretty much exactly what happened. We just were trying to pull together some sort of policies, data collection, everything. And then we had our first exchange 6 months later after it became legal on December 1st, 2016. And at that time, we had 1 organization doing syringe exchange, and now we're up to 8, which we're really excited about. But again, it's kind of been different, and we've scrambled to try to find people funding, and where we could get funding, as you guys both talked about. We scrambled to get policy changes and support, community support. And I would say that probably, I mean, there's so many successes over the last now almost 5 years, which is amazing. It's aged me, I think, 50 years, but over the last 5 years, you get that. we've been able to grow our program. And I think the biggest success, like the others have mentioned, is just gaining a better understanding of people who use drugs, of harm reduction, of what syringe services are about. Because at the beginning, even the leadership at the health department was very narrow in their thinking. And I think that working to broaden and include all those other services and expand into really larger collaborations has really been probably our biggest success and the biggest thing that we're most excited about. And we're facing a lot of challenges now. I know we'll get into that more later, but I think a success and a problem is we have more clients than we know what to do with. All of our providers, most of them are located in Salt Lake City, which, like Missoula, is a blue dot in a red state. And, you know, most of our clients are here as well. However, you know, we have, of those 8 organizations, 7 of them work primarily in Salt Lake City or Salt Lake County, and they are all overwhelmed. So they are mostly unfunded. So trying to figure out how to, now we have this demand, now we have this expectation, we've built that trust, we've built that support in the community, and now they rely on us, and we're just reaching the end of our rope, and that's really challenging. So it's both a success and a challenge in that we have so many clients and so much embracing of these services, but it's really kind of opened Pandora's box in a lot of ways as well.
Thanks, Heather. I think that's a really interesting framing, right? About sometimes, we get really successful, but then it kicks up a whole bunch more challenges, right? As if there aren't enough challenges in doing this work as this. But yeah, so that leads us nicely into the next question, right? That I have part of the conversation about, like, what are some of those challenges that you faced, and whether you're still facing them, how you overcome them? And within that, you know, you all touched on the legislative pieces, right? The policy pieces, and how they play a really important role in part of, like, you know, as part of getting yourself going, or being a challenge to getting yourself going. So, you know, I don't know who wants to go first. I'm going to let you choose amongst yourselves. But I see that Loris is off mute.
Yeah, there's like I'm writing notes to catch up with some of the things, and also like focus on what's going on in the chat. But you know, like we talk about like policy, like in California, we had recently passed AB 2077, right? So that allowed extended, you know, kind of reduce some restrictions around pharmacies being able to sell syringes without a prescription. And then, you know, what was kind of slipped in there also was just the fact that drug using materials that are distributed at programs are no longer considered drug paraphernalia. That's a win. Then the challenge with that, though, is, you know, you can have law in place, but then what happens after that, right? So we know that harm reduction materials are no longer considered drug using or drug paraphernalia, but we still have participants who are being harassed and arrested by law enforcement for having it in their possession, right? Then you have, you know, the green light has been pressed for pharmacies to, you know, the buzz term, the new sexy term now is pharmacies as prevention partners. You know, that's like this new thing that's going on. So it's like they now have the capacity to do this, but they have, you know, they have apprehension, right? And so that is a challenge. And then I see in in the chat, like there's something that was, I think, Lorenzo mentioned something about, like, you know, how opioid changed everything because of the population that it affected. And, you know, it's interesting because, Emma, you touched on this where you were saying how consistently the name changes around the services, right? And then someone also touched on the fact that, you know, pipes, like California is able to distribute smoke pipes as well, and safer snorting materials. And, you know, it's more than the syringe, it's more than syringe services. And so one of the challenges with that, you know, is that we're getting folks to, I feel like, you know, we're trying to get them to catch up, right? So some folks are still viewing syringe services as exchange, and they're hung up on, you're giving out syringes, you have to get back syringes, even though there's countless studies that show that it does not increase, crime or litter, that sort of thing. So I feel like one of the challenges that we're experiencing is, we are doing the work, we're in it, we're doing the work, and we find that we're moving in this momentum of, oh, this is harm reduction. This is opioid overdose death prevention, right? And folks are still, and those folks, I mean those who have the capacity to make change, are still seeing it as syringe exchange, or dare to say, you're enabling. So yes, I'll stop there.
Thanks, Loris. Yeah, Stephanie, I see you unmuted. You ready to jump?
I know. Well, I feel like, I have so many things I want to comment on, and Loris touched on so many things that I want to follow up on, just in Montana. But that legislation too, one of the challenges is that as a provider, we're protected, but our participants are not. And I think that it would, at a point, we need to get to a place where we do have legislation that does protect our participants, especially when they're en route to disposing of their used supplies in a safe manner. But there is still that, what's on the books is one thing, but how it plays out in reality is another thing. We have a Good Samaritan law, but we do know that law enforcement still, if they do show up to the scene of an overdose, well, now they can no longer charge folks with drug crimes. They might run their names and find out that there's a warrant out. And so, you do realize that there is a lot of educating participants that is also very important, with letting them know that this is the law, yet this is also the truth of what happens. And so we still, one of the challenges is still trying to educate participants on their rights legally. And so even though, we are hoping that we can get to a place where syringes and other supplies used to inject drugs are no longer even considered paraphernalia, there is still going to be work to be done. I also wanted to talk about just with, the stigma associated with people who are using drugs and injecting drugs, what Lorenzo, his comment about everything changed because of which part of the population was affected. In Montana, a couple of years ago, if you were driving down I-90, you would pass a series of billboards. And you would pass a billboard that there was a clean-cut, Montana man, and it said, opioid use disorder is a public health emergency, a public health issue, and we need to be, essentially we need to be very compassionate towards people who have opioid use disorder. You drive a few more miles down the road, and there is a Montana Meth Project billboard with a very, very stigmatizing image of someone who's using meth, and the message that not even once, or your life will end in tragedy and destruction. And I think it's just a visual reminder that as harm reductionists, we have so much work to do with the people that hold the power in our states, because rather than seeing a group of people that are using one type of drug in one way and another group of people using another type of drug in another way, we need to get to the place where we care about all of the people who are using drugs in our state and value all of them as the human beings that they are. And so I appreciate, Lorenzo, that comment, because it is so true that there's this interesting hierarchy, and we definitely see it in Montana. And so one of the challenges that we have is trying to make sure that we are battling that stigma all the time, and trying to break down that.
So Stephanie, you mentioned something about in your intro about messaging and like education, and I made note. It said, I just put like public messaging. Could you talk a little bit about that? Sorry, because I really want to make sure.
No, great, thank you, Laura.
Well, and I think it, because we were sort of the first of the, above ground, publicly accessible fixed sites. I don't really know how you want to talk about it, but we have done a lot of educating our community members, not just in Missoula, but wider in the state of Montana, and with just basic, it's almost like harm reduction 101, and trying to get people who have zero foundation of harm reduction. Everyone knows harm reduction when it's sunscreen or seat belts or cigarette filters, and trying to make that connection with folks too, that listen, you know what harm reduction is in all of these other aspects of your life. For whatever reason, when we're talking about harm reduction and drug use, it's radical and it's controversial, and there's these moral ideas we're placing on people of how they should act. And so I think that the public messaging is kind of getting down to the basics and talking about how harm reduction is so pragmatic. I mean, if you don't care about the people that are using drugs like we do, there's all of these other reasons that harm reduction just makes sense. And you should want to implement harm reduction in your work and all around the state. And it is interesting too, because you oftentimes find that people that you think are going to be really resistant, once you start getting just down to the basics. And the Harm Reduction Coalition, they helped us in our early days back in 2013. And I just remember talking about all the pillars of harm reduction. And we always go back to that whenever we're talking with someone who doesn't understand. And I think offering that foundation is always where we start. I don't know if that was helpful.
Thanks, Stephanie. Yeah, and I want to bring it to Heather, because I think what resonates with me there, Stephanie, is that, and Heather, you alluded to this, how we get that buy-in, how we build that trust, right? To Anshay's question in the chat, because from my own experience of doing that work as well, I find that we're unpicking a lot of what people has been taught is common sense. To them, what is common sense is, and so common sense, so sometimes harm reduction can feel really counterintuitive to what they've been taught in the past, and we're kind of doing a lot of that unpicking and re-educating, or in terms of getting that buy-in. So Heather, I'd love to bring it to you, to speak about how you approach that in Utah, and kind of any other challenges that you'd want to uplift in terms of what you've needed to overcome or you're still facing in your state.
Yes, thank you. And I can really echo a lot of what Loris and Stephanie have said. A lot of those same issues. It's kind of interesting, you take someplace like California, someplace like Montana, and then Utah's kind of a mix. I mean, we're geographically kind of in between, but I think we're also a lot of the ways in between. One of the things that we do not have is our drug paraphernalia law is really in conflict with our syringe exchange law. So we do have challenges there quite a bit. However, for many reasons, we have chosen to kind of lie low as far as addressing that, because for many reasons, working just kind of directly on gaining support and understanding has been really effective. And I think we're getting to the point where maybe we can address it, but some of our fears were we want to continue to fly under the radar so that people aren't too aware of what we're doing, if that makes any sense. And so it's kind of both that thing of trying to improve those public messages, but also trying to keep syringe exchange for the people who need it and not draw too much attention to the people who might object to it. And that's worked fairly well, strangely enough. We do have some areas of the state who, like Stephanie mentioned, who have been a little more resistant, but then have been accepting with approaching it in different ways. Like Loris was saying, approaching it from kind of an overdose prevention way or a disease prevention way. But one thing too that I think has been really interesting is working with substance abuse treatment providers and having them embracing harm reduction and that harm reduction is not in conflict with traditional substance abuse treatment, that it actually is part of the same continuum. And I think that's been both a challenge, but a real success that we've been seeing as well. And I really think that that's what is one of the most important pieces is just continuing to be there to advocate for those populations and for people who use drugs as being like what the National Harm Reduction Coalition always does, as, you know, as being people too, and people deserving of these resources, people deserving of basic human rights and healthcare. I mean, we're, you know, a long ways away from that. We face so much stigma around so many other things, but I think continuing to try to knock down some of those barriers and just being a presence. What we have also found by kind of flying under the radar is that a lot of the fears that people had about syringe exchange, because it did kind of just hit Utah in one fell swoop and everyone panicked and freaked out, including myself a little bit, because how are we going to do this? But, you know, there are images of rivers of syringes running down the street, and, you know, that it bringing, we actually had state legislators say that they thought syringe exchange would actually attract drug dealers and people who use drugs to Salt Lake City because they were going to come to get our services. And we're like, no, syringe exchange works the opposite way. We go to where people already are, where this is already happening. This does not attract. And that has been a big thing to overcome. But a lot of the way that we've overcome that is just by being steady and moving forward and showing them that this is not the case. A lot of their fears are unfounded.
Heather, I'm really appreciating those examples you uplifted there around. Yeah, I've seen this in other states as well. I know the localities where people have done that balancing act, right, between just enough awareness but not too much, and that but a part of that example is that thing where, and then when people did become more aware, they already had the examples to go, see, it's working here, right? So you don't have to be so afraid of it, you know. Yeah. So I really appreciate you sharing that example with folks. And the other thing is, yeah, about engaging that substance use treatment folks, right? Those staff that I find are often like very scared about what this means for them. You know, I've had those staff in trainings that are like, but do I have to like let go of everything I've learned? And so the way I frame it is like, no, I'm just bringing you more tools. Like, use the tools you've been using, but here's some extra tools so that you are not just helping some people some of the time, you're helping more people more of the time. And so I found that that's a really helpful way to frame it and build those relationships and trust with them, so that, because I think a lot of it is people coming to this with fear, right? In a range of examples that you've all shared. I had a treatment provider in upstate New York who was like, yeah, when I really learned about it, I felt so freed up in my practice that I can now incorporate these additional pieces to help the folks, you know, to do my work. And I feel less stressed out. So that's an example I share all the time. Like, this can make your life less stressful. So just in the time we've got available, I want to kind of, we've got about 9 more minutes, and I want to also maybe give us a few minutes at the end in case there's any extra questions from the audience. But COVID-19, obviously a big part of the last year, right? We're at the 12-month point for many of us of when things shut down, and we really had to pivot the way that we were working. What are some of the lessons that you're taking away from COVID-19, either lessons or things that you're like, you know what, that change we want to keep, right? We want to advocate to keep that. And anything else generally that you'd want to share with this group about your experience and things that you've learned along the way that have really sustained you in your work?
I'll try not to take up too much space, but you know, the first thing I'll say is the sky didn't, I wasn't going to even say a cuss word. The sky didn't fall. The sky did not fall when they increased telehealth services and some syringe service programs. The sky didn't fall when folks transitioned, to adapt to COVID, right? By doing less restrictive syringe distribution of 1-for-1 and switching to needs-based so that folks can reduce their frequency of visiting, right, during COVID. the sky didn't turn black. You know, so it's like just understanding how, I have to say this, like programs are really good because of how they come about, right? They come about as in reactive mode to address a need. So when COVID hit, programs pivoted and said, okay, we're going to do food truck style distribution. You know, we're going to make sure that we continue services. We are an essential service. And the only thing that lacked around that was just the lack of, you know, I call it human interaction, right? And then one thing I'll quickly say as well is COVID is a really good opportunity for us to push harm reduction. Just, you know, like we're talking about educating and awareness. This is a good opportunity for us to get those who can't quite wrap their head around it to understand it more by using COVID, by using masks, how challenging it is to change a behavior by putting on a mask when you walk out of the, you know, so yeah, I'll just say that. And
thanks. Yeah, thanks, Loris. And I want to uplift us in relation to that. We had an office hours session yesterday, and if you didn't see it, you can get the recording as well. At the moment with COVID vaccine hesitancy, right, and how harm reduction can play a role for people that don't want the vaccine, either yet, they might change their mind, or never, right? There's a whole bunch of harm reduction messaging you can use to, you know, to work with folks around safety and risk reduction in relation to that, right? So yeah, I love that point.
Yeah, and just understanding that programs, like the programs, they give out more than, you know, getting to that broader. They were giving out PPE to folks. They were giving out, working with folks who were unhoused. Yes, okay.
Yeah, absolutely, Loris. Heather, I see you off mute. Yeah.
Yes, sorry to jump in, Stephanie. I just wanted to say that, so a year ago today, we had just gone into lockdown in Utah, and we had an earthquake. So everyone was already panicked, and it literally did feel like the sky was falling that day. And I remember waking up and the earthquake went off, and I went, you've got to be bleeping kidding me, because we had just, everything was falling apart. Now literally the earth was shaking beneath us. But the point I'm bringing up is, just like Loris was saying, our SSPs so quickly pivoted. They just kept going. They, even with the lockdown, all the things, the earthquake, everything, they had some slight bumps. They scaled back some of their services. They tweaked some of their services, but they were still out there every day. And we actually did a report about 4 months into the lockdown where we compared our services from that 4 months to the same time the previous year, and everything had increased. We had more clients, more services, more encounters, and it just showed us that people need these services. These are beyond essential services, and that it was so needed for people because many times it was their only point of connection. Many times it was their only point of really getting COVID information, because many of them had no idea what was going on because they didn't have access to news sources or anything. And then we were able to give them PPE. We were able to provide them with those things. So I think that in a lot of ways, COVID actually just was a bonus. It really helped us recognize that the SSPs are an important part of the community and they need to be here. And I think a lot of organizations saw that as well. And they were also a place that even some of our local health departments referred people to SSPs because they were not offering services, but the SSPs were.
Right. Thanks, Heather. Yeah. Stephanie, if you want to.
Yeah, I'll just kind of echo a little bit of what Heather has said, because I think that that is one of the things that we noticed is that, you know, at the beginning, the main challenge was figuring out how do we modify our services to keep everyone safe. And we moved quick though. And I get goosebumps when I hear Loris and Heather talking about like the pivoting and how quickly, you know, it's like, we're not going to stop doing what we're doing because we know that this is important and we are passionate about this. We just have to figure it out. So what we, you know, at Open Aid Alliance, we started limiting our fixed site hours, but then we implemented a delivery system, a delivery program, and we really expanded our mail-based program. And holy moly, that has blown up. And we are now sending packages all over the state of Montana, and it's incredible. And our delivery service as well. We have people can text or call, or we have a little form online, and we will go to their home, a gas station, wherever they feel comfortable meeting. And it just, the power of, you know, trying to figure out how we can continue doing what we're doing safely has shown us that, oh, we're definitely going to keep doing this in the future. I mean, our delivery service and our mail-based service, those are going to continue into the future. Absolutely.
Yeah, I really appreciate you lifting that up, Stephanie. And that, yeah, we've seen programs pivot their modeling in a way that they didn't even think they could, or that they didn't think they would have permission to do so. I've got programs in Michigan I'm working at the moment that are doing that, like curbside pickup and like home visits, that as a health department in particular, they never thought they'd be allowed to do. And they are planning to keep it. They're not just going to go back to fixed sites. And also, yeah, the expansion of opportunities around mail-based programming, you know, yeah, really, like, yeah. And my other pet one I'm just going to share with folks on here is, can we please, like the places where we've relaxed the rules on prescribing methadone, please can we keep those in place? We don't need, you know, the early research, there is some very early research coming out about, you know, all those fears that people have around methadone prescribing, of people, like if we give them too many take homes, they're going to increase their overdose risk, it's going to cause more diversion. The early research is showing that that was not the case. So like that's another area that I think I'm hearing come up an awful lot in terms of what are some of the things from COVID we really want to, we've been advocating for that for years, right? That methadone prescribing is so like difficult for people to access. So yeah. Loris, were you going to say something? I see you.
No, I was just gonna say, this is proof of, you know, like it dispelled like this, you know, like the myths of a person who uses drugs, that they can't be responsible or be mindful of their own health, right?
Yeah.
It's just another example of the sky not falling. I just
exactly.
Yeah.
Joanna's given us permission to go a few minutes over into the break. So if folks have any final questions, you know, that they'd want to pop in the chat box, or if, you know, my panelists, there's something like that you're like, oh, I really want to say this, like I got my methadone prescribing plug-in, and there's anything else before we finish up and take a break.
I just wanted to say one thing as a piece of advice. If you're not, somebody's at my door, but whatever. If you're not working with your state health department, work with them, get them on your side. Because, you know, there are people like me and Loris who are your advocates, your support, your, you know, will take bullets for you. We have resources that maybe you do not have, and ways to help you improve your programs. And if you don't have an advocate at your health department, try to find one, and maybe you can reach in and educate them and bring them on board. And start with your overdose team as well as your HIV and Hep C teams.
Absolutely, Heather. And vice versa, I think, right? If you're on this call and you're a state health department rep, make sure that you're checking in with the existing programs, right? Because we've also seen tensions arise where health departments start to do work, but they haven't really engaged with the people that may have been doing this, like to Stephanie's earlier point, either underground, or they're just, you know, or have been doing, there's legacy programs out there that have been doing this for a long time. And sometimes health departments, with the best of intentions, come in like with new money and new resources, but you gotta make sure that you're connecting with your harm reduction folks that already exist and having them help you, guide you and lead you as well and inform you. So I'd say that, like, you know, there's that vice versa to both of those examples. I hope is helpful to folks. Just checking the chat box. And also, if anybody asked anything earlier on in the chat, because I'm not very good at going back and forth in the chat, if anybody asked something that they didn't get answered and you just want to pop it back in this part of the chat box for us, just let us know. Well, I'm not seeing anything else pop up. unless I'm not a fast typer, so I'm going to give people a minute. But also just to reiterate, right, if people have, we know if you're reflecting on it, I'm also someone that sits and processes and usually has that, oh, damn it, I wish I'd thought of that question. Like in the thing, if anybody has, okay, we got a question from Anshay about racial disparities. Does anybody want to speak around kind of that aspect? I know I have some things.
I will just say this. I will say this because when I just saw that in the chat, the first thing that jumped out for me, I'm trying to, I may say it raw, just want to, you know, just state that out loud. For me, you know, it's frustrating when Lorenzo, you know, touched upon, you know, how efforts changed when the face of the epidemic changed. And I just remember, you know, back in the day, you know, just like really trying to like advocate and share, like, we have a problem, we need help, and it just really going on deaf ears. And then once it changed, you know, resources became available. And not only did resources become available, but it was more of this, you know, it's kind of like they just tucked it under the rug of not didn't acknowledge the fact that this is something that communities of color have been screaming and hollering for a while.
Yeah.
Instead, it was like, you know, I felt how I always describe it as a reset button was hit, and then everything that happened in the past just, you know, turned into a blur. And it's like, oh, this is how it's always been. You need resources? Yeah, we have some for you. You know, so there's that. And then the other piece too, in terms of racial equity, when you think about just harm reduction community or in general, like there really needs to be more folks of color, you know, in leadership roles. There needs to be more folks of color at the table talking about it, because, you know, harm reduction, you know, when you think about drug user health, it's something that communities of color have been doing for donkey years. I mean, it's just something that we've been doing for eons, and, you know, it's in practice, it's in our lives, it's in practice, and, you know, just kind of need to catch up around that. And I have to say too, though, it's really good to see, you know, some diversity in our panel. I know we have some folks from Vegas. You're on, can't see your video. Hey, person there, Chelsea. But it's good to have, you know, folks of color being at the table and speaking on it. So yeah.
Yeah, thanks, Loris. And I'd add to that, like, definitely, like, you know, I share this example, and Dr. Tux doesn't mind me sharing this example from Miami, right, where they started their exchange in Miami, in Overtown, right, in a historic African-American community in downtown Miami, right, hardest hit in terms of HIV. And when they first started, the majority of the folks that came were white folks, like white dudes on their bikes that would come get their stuff and go. And the black folks weren't accessing the services, and we had to have a real we had a great conversation with the team about how to be representative, how they needed to be doing outreach to the local community in greater depth to engage people and find people what their needs were, what their challenges were. I was staying in an Airbnb just around the corner, and I could see from where I was staying the police presence, right, and how black folks and communities of color feel over surveilled, and so felt like we were saying maybe, you know, the surveillance is what's keeping people away, because, you know, if they're going to be profiled very differently to the white kid on a bike that comes by and gets their syringes and bikes off again, you know, so like having those kind of very intentional, explicit conversations about racial disparity and how we engage communities that, you know, historically the war on drugs is treated very differently than white communities when we saw the uptick in opioid use amongst middle-class white folks. You know, and the other area that very tangibly for me when I'm training folks is like, I get people comments of like, well, why wouldn't people call 911 in a community of color in an overdose situation? I'm like, because people have died when the police turn up. Like, so really understanding very like those genuine fears. Or there's a great filter article that I'll share actually so that Joanne can send it out about how we as harm reductionists show up in communities of color and why like there's often resistance to harm reduction because abstinence feels like safety. Because harm reduction can feel very dangerous if you're over surveilled by the police and like, you know, the impact that might. So we have to be very sensitive, because I've had harm reduction say to me, well, they told me that it would lead to genocide and they were very upset as harm reductionists. I'm like, but can you understand why you are getting that reaction? You know, so being very sensitive and mindful of, it's the same thing with COVID hesitancy, right? Understanding why some communities are not trustful of the health system because of health, racism in the healthcare system in terms of getting the vaccine. So like just employing that sensitivity and intentionality and having those explicit conversations, right through to your service delivery models, I think is super important.
I just wanted to make one really brief point about that. Sometimes I face the challenge from our SSP providers as well, because Utah's a very white state. So even though the majority of our SSP clients are also white, I try to address with them, that doesn't mean that there's people out there who are not accessing our services because they see it as not for them. So how can we be finding those communities that are maybe even more underground than they are in other places, because it is such a, very white state. But we do also have a lot of Native American populations, a lot of Hispanic populations, a lot of Spanish speaking. We actually have a very large African refugee population here. And so it's really been challenging to try to get them to recognize that. But I think also part of the problem is we're so overwhelmed. It's not like we're looking for clients, but we don't want to leave people behind either.
Yeah, thanks, Heather. So, we kind of ate into people's break. I'm sorry about that. Thank you, Joanne, for letting us have a bit of time. And, we could continue these conversations. There's so much rich stuff to unpack here. I'm hopeful that this kicked off and started the people thinking, and please reach out to Joanne's team. They can help also connect you with us or any of our speakers if you're like, oh, I really need to I need some more support around any of the issues that have come up in today's initial panel. I want to say a huge thank you to our panelists for sharing your treasure and wisdom with us. Again, I just want to say thank you. It's such an honor to be able to facilitate and kick this summit off for you. Thank you.